Hey guys, welcome to Man Medicine. Today we're going to do a Q&A. I get some really good questions from you guys. I do my best to try to answer them in the comments section of the particular video, but it's really hard for me to keep up with those. So what I thought I would do is collate a whole bunch of some of the more recent questions that I've gotten like within the last like roughly 30 days, and then just try to answer them all in these kind of Q&A videos. So thank you guys for submitting these questions. If I didn't answer your question, it's not because I didn't think it was a good question. I just, I had to cut it off mainly just due for time reasons. So doesn't mean I won't get to it in the future. If you want me to give you a detailed answer about a question, leave it in the comment section of the particular video. And what I'll more than likely do, so that I don't just give you like a short cursory answer on my phone, is try to record, a more detailed answer for you in a video session like this. So if you guys like this, let me know. I'll definitely keep doing it. If you'd rather have me just do like specific subjects and like I've been doing, we can totally go back to doing that. It doesn't matter to me. So, but again, you guys have asked some really good questions, and I feel kind of bad because I can't always give you the level of detail that I like to do. I'm a detail-oriented guy, and it's really hard for me to type on my phone in the middle of a shift or whatever I'm doing and give you an appropriate answer. So this is a format that I can give you a more detailed answer to some of your questions because they have all been really good. Okay, without much more ado, let's do some questions, okay? And again, these are in no particular order. The other thing too, legal disclaimer here, this is not specific medical advice to you or to anyone else. Okay, I'm doing this for educational, entertainment reasons and to just inform you guys. You're getting my opinion in here, so I'm not telling you what to do in this particular video. If I have one of your specific questions, this is not officially medical advice. Go talk to your doctor about it. But I'm hoping that you still find this useful. So, okay, first question here. It's not really a question, but more of a statement. This was related to one of my hematocrit videos, and he writes, I'm not going to say the names of the individuals. I'll just paste the question up there on the screen. I'll cut the name off because, I don't have your guys' explicit permission to put your names up there, so I'm not going to do that. Anyway, it says, you fast for your blood draw, wake up, hop in the car, go for the draw. After you get coffee, food, and so on. I did all of this and was basically dehydrated. Okay, yes. Many times if you fast overnight and, go right in and get your blood draw, even if you had a cup of coffee or, something like that, you're going to be a bit hemoconcentrated, as we say. And so, yeah, your hematocrit might be a bit higher than it normally would be on a day where you didn't do something like that. They told me to donate blood. Of course they did. Is donating blood a bad thing? No. Okay, we'll talk about that. Regardless, drinking water and keeping hydrated is important for the blood draw. Yeah, absolutely. I tell my guys to pound water before the blood draw. I generally don't make them fast unless I'm doing specific fasting labs that I need. Fasting insulin levels, of course, you need to fast for those, that sort of thing. But in general, I don't require guys to fast. I didn't want to think about eating or drinking, and some days I do dry fasts. So if they said to be sure to drink water rather than you can drink water. Okay, not sure what you mean by that. But the question buried in here is donating blood a bad thing? And he says no. So yeah, I mean, I donate blood. I do it about twice a year. I do it for altruistic reasons. I use a lot of blood products on my patients in the emergency department. And so, I'm O positive. So yeah, I donate blood to help replenish the supply as best I can as a single individual. However, if the way that your provider manages your elevated hematocrit, first of all, it's a whole other series of questions about whether we need to manage that at all. However, let's assume that your provider thinks it's important for you to maintain a certain hematocrit, whatever number that might be. And the way that they do that is they have you go to donate blood every 2 months. That is a terrible idea. That is a poor plan. And the reason I say that is because eventually, not sure when, it's going to vary, you'll become iron deficient, right? You're going to tank your ferritin and you're going to feel terrible, more than likely, and it's going to adversely affect your health. So if you have a persistently elevated hematocrit, if you perceive it to be a problem or your provider perceives it to be a problem, donating blood as a long-term plan to address that is not a great idea, okay? You need a protocol change. There's something wrong with your protocol, something that needs to be changed, whether it's the dose, the frequency, the delivery method. I'll leave it up to your doctor. There's a lot of different ways to mitigate elevated hematocrits. Most of the things that you read on TRT forums are completely wrong. They don't work. But what I can tell you with absolute certainty, because I've seen this so many times, is that if donating blood every 2 months is the way that you control your hematocrit, it's only a matter of time before you become sometimes profoundly iron deficient. And some guys feel that a little bit, and some guys feel it quite a bit. And you can dig yourself into quite a hole, to the point where you need intravenous iron infusions to get yourself out of that hole. I don't recommend regular blood donations as a way to manage your hematocrit. It doesn't work. It depletes your iron, and in the long run, it's going to cause more problems than it solves. So enough on that. I've talked about that at length in the past. So, all right, next question. I'm going to put my glasses on here so I can see this a little bit better. So not that long ago, I had LASIK done, but I had the monovision procedure done. So my right eye is for distance vision and my left eye is for up close. So, but the problem is the way that they did it. So it works really well. That my up close vision, but is good, but it has to be really close. And then my distance vision is unchanged because they didn't really do anything with the right eye. But there's this middle space now, and it's right where my monitor is that I'm a little bit blurry. So, and unfortunately, it's right about the space, right around the distance. It starts to get blurry where somebody's vocal cords are when I go to intubate. So that's a bit of an issue too. So I still need these. So I was hoping to get rid of the glasses, but I still got the glasses. So anyway, overall, I'm happy with the procedure, but it didn't allow me to get rid of my glasses, which is kind of what I was hoping for. So anyway, this one is for the patients that have venous insufficiency and lymphatic problems. Is TRT/HCG going to worsen the situation? Yeah, absolutely. It could. It could. I freak out. I freak out when I don't consume beetroot and rich potassium foods. Yeah, don't freak out about that, because I get swollen in 2 seconds flat. Thanks. Okay. So yes, taking testosterone, elevated testosterone levels can cause fluid retention, and through a variety of different mechanisms. And the renin-angiotensin system often gets upregulated, especially early on in therapy, and so you can have some fluid retention. Now, if you have normal functioning kidneys, you're otherwise healthy, you don't have sleep apnea, and you have a normal venous and lymphatic system, this is generally mild and self-limited. If you've got chronic venous insufficiency or lymphatic issues where the fluid tends to pool in your extremities, usually with gravity, yeah, then this could absolutely get worse. And it's definitely going to get worse if you have a poor protocol. So what I mean by that is typically your dose is too high, or you're getting big single boluses of testosterone, like you're being dosed once a week. If you also have underlying sleep apnea, maybe you're not aware of that, you're obese, you're chronically inflamed, you have large amounts of visceral body fat, like all of this is going to potentially make this worse. So make sure all of those other issues are addressed. And if you're going to start on testosterone, if you have venous insufficiency and you're going to start on testosterone out of the gate, being very conservative is with the dose is probably the right thing to do. And then you can always go up on the dose, right? If you start having issues, you can back off, etc. Anecdotally, I rarely, if ever, have had to use diuretics to manage this. I could imagine that there are some situations people have very severe lymphedema, very severe venous insufficiency, where maybe even a loop diuretic is something that they're going to need to have in their armamentarium. It's not something that I've had to do. I can think of a couple cases over the last few years where I've had to give somebody a brief course of a loop diuretic to handle edema issues. It's very, very uncommon. However, an ACE inhibitor or an ARB sometimes is sufficient. It goes a long way. And you know what? Has some other health benefits too. So that's something that you could consider in the mix. Talk to your doctor about that. But this is a mechanical problem, right? Your veins, typically there's damage to the valves, and so the blood just pools. So you just got to manage that, and you've got to see somebody who understands the vascular system, who understands the cardiac and the renal system, all these things together, and how testosterone influences that, so they know how to manage this for you. So best of luck. All right. Next question. I have pre-existing gyno that flares up when I take testosterone. What should I do? Okay, I've got a long video on gynecomastia, so the answers are all in that video. So I encourage you guys to watch that if you have questions about gyno. Gyno's a lot more complicated than people think it is. But having said this, this particular individual, they say they have pre-existing gynecomastia. Now, I'm going to assume that you have genuine gynecomastia here. So genuine gynecomastia is proliferation of glandular tissue. Okay, it's not fat tissue. The majority of men who think they have gyno actually have pseudogynecomastia, and it's trying to put this a nice way. You're too fat. All right, you've got adipose tissue around the breast. It certainly can look like gynecomastia, but a trained clinician who examines you should be able to tell you right away, okay, this is fat tissue. It's not glandular tissue. The answer here is for you to get leaner, and it's going to go away, or it's going to get much, much better. So having said that, if you've got pre-existing glandular tissue there and it's an issue, I hate to say it, the only viable, in my opinion, long-term solution for this is surgery. Okay, it has to be removed surgically. Using an AI, using a serum like tamoxifen, people can do this stuff in the short run. It's not a long-term solution. You want to take tamoxifen for the rest of your life, or you want to take anastrozole for the rest of your life and suffer all the potential long-term health consequences of that. I mean, I think that's a pretty bad idea. So I don't recommend that. If you've got pre-existing gyno, whether it's something that developed when you were in a young adult or teenager, which is very common, or whether you use PEDs, you've got a genetic predisposition to this. This is something you probably will be dealing with for the rest of your life. Personally, I would go get it cut out. I know it seems a little bit extreme, but really that's the best solution for this, is go see a competent breast surgeon and have an evaluation, confirm that it is in fact glandular tissue, and then that's what I would do, is I would get surgery for this. All right, I hope that answers your question. Moving on. Okay, this is related to blood pressure. And this is a good question because it brings up a few important things that I like to harp on. So he's talking about his blood pressure here. He says, mine is sometimes 121/77, which is great. So, based on available data, you should average over a 24-hour period. We'd like you to be under 120/80 to reduce your risk of adverse cardiac events, stroke, a heart attack, etc. It says, then some evenings it's 1/90. Yeah, I mean, that happens. So that happens to me too. That happens to me too. So I don't have hypertension. I do take a small dose of telmisartan for vascular protection and age-related issues. However, I generally live under 120/80. Not that long ago, out of curiosity, I took my blood pressure at work. It was like at 1 a.m. I had just run a cardiac arrest for about an hour and a half. It was really long. It was really gnarly. Got the guy back. My blood pressure was like 160/110 right after that. Okay, that's normal, right? Like, I just went through an extremely stressful event. My catecholamines were high. I had pounded a bunch of coffee before that because I was really tired. It was like my 4th shift in a row. So, under those circumstances, it's normal you're going to have an elevated blood pressure. If I had checked my blood pressure then and it was like 115/60, which a lot of times it is, I mean, that would have been abnormal, right? It would not have been normal to have that blood pressure under those circumstances. So just take into account what's going on in your life at the moment. How hydrated are you? How well did you sleep? Did you take any stimulants? And most importantly, this is kind of a pet peeve of mine, make sure that the blood pressure is taken in the correct manner. I have yet to ever go to a clinic as a patient or work in a clinic as a provider or in the emergency department or hospital, inpatient or outpatient side, where the blood pressure was actually taken properly, meaning where they follow the American Heart Association guidelines for how to take a proper blood pressure, which means you go in, you sit down, it's a calm, quiet room. Okay. You sit quietly, both feet flat on the floor, legs not crossed, for 5 minutes, and you don't talk, and it's nice and silent. Okay. And then they come in and they put the cuff on, and it has to be on bare skin. So not over your shirt or your sweatshirt, which I see all the time. I catch the nurses doing that all the time. I'm like, come on, Like, we know better than this. And then you do 2 readings at least in 1 minute apart. Okay. That's how you take a proper blood pressure. Nobody does it. So if you've just been like arguing with your spouse, or like you just ran in to the house after you've been out, you parked your car, ran in to the house, sit down, boom, just take your blood pressure, it's going to be elevated, right? So chill out about 5 minutes, feet on the floor, try not to talk, be in a quiet room. Do it. Don't take stimulants or caffeine, nicotine, anything like that for at least like 30 minutes or so prior to that, so you can kind of get that out of your system. And then that's what your blood pressure is. Okay. So having said that, if you are consistently this high or higher in the afternoons, then that might like blow your average, right? Your average might be greater than 120 over 80. And so you need to look into that a little bit. Why is your blood pressure up? Have you gained weight? Do you have underlying sleep apnea? Have you been slacking off on your cardio, right? Cardio is a big one. Are you getting enough potassium in your diet? So potassium supplementation might be something you can do to bring this down. And then finally, if need be, medication. All right. So that's that's how that's how you address hypertension. Okay. Sounds like most of the time you're okay. And then you have periods of time during the day, perhaps, when it's above range. If these are like isolated incidents and it comes back down to normal, like, that's fine. I wouldn't like go throwing prescriptions at you. Try to address, like, what do you think the underlying cause of this is? Okay. All right. Next one. Okay. This is from one of the Estradiol videos. It's funny, I see this video today. My doc wanted to put me on an AI because my test is 1222 and my estradiol is 67. Oh, dear Lord. Oh, heavens to Betsy. My estradiol is 67. That's a great reason to go on an AI. I am 46, but all my LDL I got down to great numbers, and my visceral fat has come down to 213. Okay, I'm still a fatty, but don't want to get on an AI. Good for you. I feel fine, and maybe a little itchy nips. Okay, again, not a guy. Itchy nips is not gynecomastia. But told them I won't get on one at this time. Good for you. I would say right now about 23% down from 30%. So ways to go left. Listen, good for you, man. That's kudos to you. This is really good. Okay, 30% body fat, you're a fatty at that point. 23%, man, I don't think you qualify for fatty status anymore. Maybe someone in the comments can tell me, like, what is the cutoff? When do you become a fatty? I don't know. I would say 25% and above, you're probably getting into fatty territory, but 23, man, that's pretty good. So, give yourself a pat on the back for that. And also give yourself a pat on the back for declining an intervention that is bad for you, that your doctor was trying to push on you. When I first read this, the first thing that came into my mind was like, okay, this guy's doing everything right. He's losing body fat. He's doing everything to get healthy. Why is his doctor trying to make this harder for him? Okay. And what I mean by that is we have very good data out there that men on testosterone, okay, who get put on an AI, especially if they crush their estradiol down, it impedes the loss of body fat. It makes losing body fat harder. So I'm like, why is your doctor trying to make weight loss harder for you? Because they don't know that they're doing that, because they obviously don't read the data. That's what happens when you take an AI. So your estradiol of 67 is perfectly fine. It's perfectly appropriate, especially given your testosterone level. Good for you. Good for you. One final thing I'll say about this. Listen, just because your doctor recommends something, it doesn't mean you have to do it, right? This is not a dictatorship, right? The doctor, he works for you or she, right? You're paying them to provide expertise. I'm not sure how much expertise you're getting if this is what your doctor's recommending. You might want to seek expertise elsewhere. But listen, they work for you. So if they're recommending something that you're not comfortable with based off your own research, you don't have to do it, right? I see this all the time. My doctor wants me to do this. I don't want to do it. What should I do? Really? Do you need me to tell you what to do? You don't want to, your doctor's trying to get you to do something you don't want to do. Don't do it. I mean, or ask them why. Maybe they know something you don't know, right? There's a good chance of that. But listen, maybe they don't. Maybe you actually know more than they do about this particular subject, right? And when it comes to testosterone therapy, I'll just say not all of these doctors and providers are keeping up. So good for you to stand up to your doctor. Proud of you. I am extra proud of you for dropping your body fat percentage 30% down to 23%. You said you still have a ways to go. You know what? You're well on your way. I would say, yeah, you do. 23%, in my opinion, is still too high. It's better than you're better than average, right? National average, gosh, what is the national average? Like 26%, I think now for men, somewhere around that ballpark. So I strongly encourage you to get down under 20%, and you're well on your way. So just keep doing what you're doing. Don't take the AI. I agree with you 100% on that. So good job, man. Okay. Okay, this is from the video on elevated liver enzymes and exercise, and it's from a female. So I've got female listeners on the Man Medicine channel. All right. um, is this similar for women? So yeah, it is. I am an overweight woman that is 64, was having mobility issues, so started working out. Okay, good for you. It's absolutely the best thing you could do for yourself, especially at your age. The fact that you're overweight and you're having issues getting around, exercise. Absolutely, you got to do it. There's no time like the present. So good for you. In June 1, 2024, I saw a PCP, August 2024, lab showed elevated liver enzymes. Okay, a GI doctor did testing for hemochromatosis. All right, good, 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 good. So it was found in my DNA. All right, so you probably got iron studies, which showed an elevated saturation, so or an iron, I call it an iron index, greater than 50%, and then they sent off your DNA and you have it. Okay, so that's probably the cause of your elevated liver enzymes. Anyways, working on that, but concerned that my exercising can elevate my liver enzymes, wondering if I should lay off exercise before labs. So first of all, definitely don't lay off exercise in general. Keep doing what you're doing. Um, I'm going to assume that you went to a GI physician, right? This is their wheelhouse. So I'm going to assume that you had a thorough workup to exclude other causes for your elevated liver enzymes, right? Because there's no law saying you can't have more than one problem. So you can have hemochromatosis and fatty liver disease. All right. You can have hemochromatosis and autoimmune hepatitis or whatever. So I'm going to assume that your GI doctor ruled all those other things out. I think that's probably a good assumption on my part. This is their wheelhouse. This is what they do. So then in this case, your elevated liver enzymes are presumably secondary to hemochromatosis that's being managed. So, how should I say this? The degree to which your liver enzymes are elevated is directly related to a few things. It's one, the intensity of the exercise that you engage in the days before you get your labs drawn. So yeah, very heavy, high intensity weight training with a lot of eccentric loading, that sort of thing is more likely to elevate your liver enzymes than going for a walk or a hike, etc. Keep that in mind. And they do track your liver enzymes. I'll tell you what. Oh, the other thing that is related is just the amount of muscle mass that you have. So I'm going to go out on a limb and say that as an overweight 64-year-old woman, you don't have an abundance of excess muscle tissue, and that you're probably not crushing it in the gym to the degree that I was just saying, heavy eccentric loads, squatting to failure, large muscle group exercises, etc. Maybe you are, which is great. But in your particular case, I don't think you need to if you're not doing that, I wouldn't get bent out of shape about this. I wouldn't say, and I wouldn't spend too much extra time thinking about it. If you want to, take 2 or 3 days off of exercise entirely, as long as it doesn't mess with your schedule too much whenever you go in and get labs, or if you just want to be certain. In your particular case, I have a feeling it's probably not going to skew the results very much. It's really in mainly men with lots of muscle mass who engage in really intense, high intensity exercise prior to getting their labs drawn. That's when I've seen this the most. So good for you. Keep exercising, keep following up with your GI doctor. Best of luck with all of that. Next one. Oh, okay. So this is a good one here. Thank you for sending this one in. All right. So this is someone who has a son who's 46 and has cirrhosis stage 4, MELD 8. Okay. So advanced liver cirrhosis, advanced liver disease. Now a MELD score, that's model for end stage liver disease is what that stands for. It's just a way that doctors can give a numerical value to the severity of somebody's liver disease, and then you can predict like what their short-term, like 30, 60-day mortality is. So the MELD score is something I learned about it in medical school. It's changed a little bit over the years. There's like a MELD 3.0 now that they want us to use. I can't remember what everything that goes into it all the time, so I just go into MD Calc. If I call up a GI doctor about a cirrhotic patient, I like to include a MELD score when I present that patient to them, because it gives, just hearing that number, I've got a 46-year-old male with late stage cirrhosis. He's got a MELD score of 8, presenting with whatever. That's already, that guy's like, first of all, he's like, okay, one, Dr. Andrew's not an idiot. He knows the lingo. Second of all, he automatically has an idea in his head of how baseline sick this person is, right? The MELD of 8, which actually isn't too bad. So anyway, that's a MELD score. He is muscle wasting, anemic, low testosterone. Yeah, super common, right? So I forget off the top of my head what the percentage of men with cirrhosis, what percentage of them have genuine, like, endocrine society qualifications for hypogonadism. It's extraordinarily high. It's very, very high. They're all weak and sarcopenic, and they all have anemia of chronic inflammation. So anemia and thrombocytopenia, which is low platelets, also very, very common. He is most concerned about the testosterone. Yeah, I don't blame him. I mean, he has other things to be concerned about as well, but 46 is not old, right? 46 is your son is a young man. Doctor told him he cannot take testosterone. Okay, well, unpack that a little bit. But from what I'm reading and seeing, is testosterone not a bad thing? No, testosterone is not a bad thing. Can help you. I think she means, can you help? Okay. What is your opinion of him taking a patch with testosterone? What do we do? I read men with low testosterone and anemia have a higher mortality rate, 100% true. He just went through all the testing to try and get on the transplant list, but they told him his MELD score is too good to get on the list. Yeah, of course, MELD is 8. So listen, that's a good thing, right? This is a good thing. You don't want to be on the transplant list, because that means you're really sick. You're really, 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 really sick. All right. So they wanted to see him every 6 months at UCLA. Perfect. By the way, UCLA is a great center for liver transplants. It sounds like you're going to get good care there. So he has to get a local doctor where he lives. Yes, please. This goes for all of you, especially if you have a chronic condition like this, something serious like this. Please get a primary care doctor. Get somebody who's competent. So get a good internal medicine physician or a very good family medicine physician who understands liver disease. Can you answer my questions, doctor? Okay, I'll do the best I can. And then this is important. He has PSC, primary sclerosing cholangitis. It's a pretty rare condition, right? Okay, so primary sclerosis. Let's talk about this disease real quick, just so you guys know what we're talking, or what he or she is talking about, and what's going through my head. So PSC is, I don't think they know really what causes it. This is an autoimmune inflammatory liver condition. It's definitely a genetic association to it as well. It causes inflammation and fibrosis of the bile duct, so bile doesn't drain properly. You get something called cholestasis, which further damages the liver. I'm trying to think if I ever diagnosed this. I had somebody I was really suspicious of back in my primary care days. And usually you go down the road to this diagnosis. Somebody comes in, hopefully they're asymptomatic, but they have a very high ALK phos, and their bilirubin might be normal. It might be a little bit elevated, but their ALK phos is quite high. AST, ALT, especially early on, is usually normal. So as you chase down the ALK phos, right, which comes either from the periphery, like bones, or it comes from the liver, you get a GGT, etc. Back in the day, if we couldn't find an obvious source, you'd get a biopsy to look for this condition. Now they do MRCs for this, so you can do things a little bit less invasively. But back in my med school and early residency days, these guys all ended up getting biopsied. So PSC is it's mostly men, and it's actually usually pretty young guys. So age 46 is kind of right in that window where this disease rears its ugly head, unfortunately. So it's not in older men. It's unfortunately in young men, like sometimes down into their 20s. And it's pretty sad because without liver transplant, I mean, it's universally fatal. Right now, to the best of my knowledge, I'm not a hepatologist, but a liver transplant is the only really way to address this, which comes with with its own set of issues. So it's a terrible disease. I'm sorry to hear that this happened to your son. So, oh, and just a little bit of trivia. Uh, some of you guys who are older, my age or older, will remember, arguably, I think we can make a strong case for this statement. Arguably, best running back of all time was Walter Payton, Chicago Bears. He died of this condition, actually, I think in his, I don't know how old he was. I think he was in his maybe late 40s, early 50s. So if you youngsters don't know who Walter Payton is, I suggest you get on Google and you will see some ridiculous highlight films of that guy. He was pretty awesome. So anyway, the question is, would your son benefit from testosterone therapy? So I'm not his doctor. Now, it says the doctor told him he cannot take testosterone. Okay. Really? Okay. I the first question that you should ask, and what I'm thinking in my head, is why. Okay. So I have a feeling, that this particular physician is lumping testosterone in with other synthetic anabolic steroids, right? So they're, especially oral anabolic steroids, are known to damage the liver, right? They cause cholestasis, which is a problem here with primary sclerosing cholangitis. So I think he's assuming that the hepatotoxicity with these synthetic drugs also applies to especially therapeutic doses of testosterone. It does not. Okay, it does not. These are separate drugs. They're not the same thing. This is the same problem, unfortunately, that we have with women's hormones, where, for example, many physicians still think that 17 beta estradiol is exactly the same thing as some of these synthetic estrogens found in, like, Premarin, for example, or they think that medroxyprogesterone is the same thing as progesterone, like you get in a bioidentical micronized progesterone product. They're different hormones. They have vastly different effects. So I think your doctor might be a little bit confused there. Now, I don't know your son's case. I don't have his medical record in front of me. Maybe there's something else. Maybe there's another reason why they're not comfortable giving him testosterone. I don't know. You need to ask the question. But this is a situation where I think if he hasn't seen an endocrinologist, I think he needs to. That would be my recommendation. It's not really fair to expect the gastroenterologist or hepatology team, who are going to be very competent in managing his liver disease, it's not really fair to ask them to also be experts in testosterone therapy, right? Again, that's not their wheelhouse. And so they're probably not the most knowledgeable people in the room when it comes to testosterone. They're definitely the most knowledgeable people in the room when it comes to your son's liver disease. So I would absolutely listen to them. The UCLA team, they absolutely know what they're doing in this department. But if he hasn't seen a endocrinologist, I think that would be a great idea. I would not take him to a local men's TRT clinic, because, quite frankly, you just don't know what you're going to get. Liver disease, especially end stage, this is extremely serious. Okay, your son is very fragile. This is a very delicate situation. You need to have somebody like an endocrinologist who has a lot of experience managing people with end-stage liver disease. There's a lot that goes wrong with end-stage liver disease. Okay, there's electrolyte issues, there's renal issues, there's blood clotting issues, there's neurological issues, and there's endocrine issues. So remember, endocrinologists have done a full 3-year internal medicine residency before they go and do their endocrinology fellowship. So I promise you, the internal medicine docs, I know this because I work with them every single day. All right. They know, they've seen a lot of cirrhosis. Okay. I see a lot of cirrhosis too. I stabilize them. I drain their bellies. I do all the initial things. And then guess who I turn them over to? The internal medicine team. All right. And then they manage them with GI's help. So I would not go to a local, like, TRT windmill clinic. I'm sorry, but this is not a dig against PAs or NPs, but unless you have a ton of experience taking care of people with late stage liver cirrhosis, you shouldn't be managing these people with 2 years of training under your belt. They're potentially very fragile. And there's a lot of caveats here. This is not somebody that needs to be put on a cookie cutter TRT protocol. You're asking for problems, asking for major, major issues. If your son goes to a clinic and gets put on the standard 200 milligrams of testosterone a week with his AI and his HCG, that could be a potential big problem for him. So he really, I normally, again, nothing against endocrinologists, but they tend to be kind of conservative. This is when you want to be conservative, okay? And then if he does well and you want to see an outside provider, okay, fine. But I can't think of a reason, just based on the information that you told me here, why bringing his levels back up into the eugonadal range, okay, would be nothing but a benefit to him. I don't have any studies out there. I actually did a literature search on this for PSC. If we had evidence either for or against testosterone therapy, there is something interesting though. Just this past May of 2025, there's a different but related condition, primary biliary cirrhosis. Okay, it's not the same condition, but it is also an autoimmune liver condition. This one's more common in women than it is in men. They gave patients with this condition testosterone in this small study from this past May, and they actually improved clinically. So, and many of their inflammatory markers, so specifically like their CD cell count activity, which is typically quite high in this autoimmune condition, it kind of tamped it down a little bit, and they had clinical improvement in their condition. So I'm not saying that that would happen with your son's condition, because again, this is a different condition, but they are both autoimmune conditions. I don't know. Unless there's something I don't know about your son's case, I don't see an obvious contraindication. We do know that, at least when it comes to cirrhosis, regardless of the cause, the testosterone can help alleviate the muscle wasting or sarcopenia, which is extremely common. It can help with the anemia of chronic inflammation, which almost all of these patients have this issue. It can absolutely help with just overall quality of life, which is a priority, right? Your son is 46 years old. He has a very serious, potentially fatal liver condition. I don't know how much time he has left, but I don't know. If it was me, my focus would be on quality of life for the remainder of the years that I have. And I don't know. It seems like testosterone could absolutely help with that. So I would defer to his team of physicians at UCLA, because again, I don't know your son's case, but if it hasn't happened already, maybe consider an endocrinology consultation, because the endocrinologist they understand your son's condition, and they also understand testosterone, hopefully, and they're gonna be the ones that can give you the thumbs up or the thumbs down, because they can have they can look at the whole picture. Okay, sorry, it's a bit long-winded, but this is a extremely complicated case. Okay, this is a good example, by the way, of there's a lot of guys that online forums, etc., that like to TRT is so simple, you can just DIY it, etc. Well, testosterone therapy is simple until this guy walks into your office, and then you have to manage him. Okay, it's nice and easy until he shows up, right? Or the guy with New York Heart Classification 3 or 4 heart failure with chronic kidney disease shows up. Okay, and that's when you need to have a physician who knows what the hell they're doing. And this is a perfect example of that. You don't want some clown clinic managing a patient like this. Okay, all right, enough on that. Let's move on to the next question. That was a good one. Oh, this is a great one too. Okay. Hey, bro, just found your channel. Hey, bro. I'll keep this short in hopes that you answer. I am going to answer it. Okay. After staying in shape, yet still having a party life up to about 2015, I started smoking about 5 cigs a day. Bad boy. Quit working out and had a big blood clot in my arm. Okay. Huge red flag. Okay. Upper extremity DVT is what this sounds like. Bad. Very, very bad. Okay, blood thinners gone. So I'm assuming like you got put on blood thinners, it went away. It happened 2 more times when I started smoking again. Okay, yeah, smoking is absolutely a risk factor for thrombosis. And quit exercising. Superficial clots. Okay, this is where I got a little bit confused actually. So, if it's a deep venous thrombosis, so veins in the deep system, right, not underneath the skin, yeah, typically those are treated with blood. Not typically, you are put on blood thinners for that. If it's superficial veins, so something like they call that to superficial thrombophlebitis, unless it's really extensive or it's creeping up and it's about to enter into the deep system, okay, if it gets within a few centimeters of that, that's an indication to be on a blood thinner. But routine thrombophlebitis, like For example, like I see it quite a bit in people who, let's say they were in the hospital and they had an IV, and then a few days after they leave the hospital or a few days after the IV is pulled out, they get this like painful red kind of like a knot, and they feel it along the vein. That's a superficial clot. So I'm a little confused here. Maybe the first one was a deep venous clot, and then the last two were superficial clots. Regardless, there's something going on here, and you say it here in the next line. So I got fully tested, factor 5. Yeah, absolutely. Yeah, upper extremity DVT, in my opinion, that's an automatic workup. And most of the time, you're going to find some underlying thrombophilia or some other cause. Sometimes it's a cancer. In your case, it was factor 5, so very common. They said either stay in shape and be good or stick with Xarelto 10 milligrams. So I stayed on Xarelto after COVID. I felt like I was getting the flu off and on every day, achy fatigue, and then it would come and go. I wanted to die for 2 years, couldn't get my T over 225, then down to 150. Wow, okay. So overtly hypogonadal. No wonder you felt terrible with that. So absolutely, excuse me. Doctors finally let me start TRT and injection every 2 weeks, and it got rid of that flu shit all the time. Okay, first of all, it's a terrible protocol. I can't believe this is still happening in 2025. Physicians out there who don't know what the hell they're doing. They're prescribing more than likely big boluses of testosterone every 2 weeks. This is a poor protocol. This is the definition of a poor protocol. Doctors, where is it? No, sorry, next line. However, my blood thickness creeps in the high range once I get around 575. Well, your protocol is not helping things for sure. And now, I don't know what you mean by your blood thickness creeps up. I'm sure you mean hematocrit. I'm assuming you're not giving me a number here, so I can't really comment further on that. I so bad want to feel even better. Okay, well, get off that protocol, find a new physician who knows what they're doing. I can donate, you should not, but I don't think the docs will let me do more, know my history. Yeah, whoever you're seeing, whoever's prescribing that testosterone every 2 weeks, they're probably not the best person to see. Any options, thoughts? Yeah, I have a few thoughts. So listen, you have a hereditary thrombophilia, okay, factor 5 Leiden deficiency. So on average, 20% of people that come into the emergency department with their first blood clot, whether it's in their legs or somewhere else, about 20% of them have factor 5 Leiden, depending on where you are in the world. So this is actually pretty common, all right? So I'm assuming you're still on Xarelto. I don't really know. Listen, if I had 3 upper extremity clots, you better believe I would recommend, I would stay on Xarelto for the rest of my life. Okay. Because, lower extremity clots are bad. Upper extremity clots are really bad. They're much closer to your lungs. Okay. So the other thing that a lot of people don't know, there's a lot of physicians don't know this. All right. And this has been well studied. If you have a clot in your arm, okay, but you otherwise feel okay. So let me back up a sec. The danger of DVTs is not just that they cause local damage to the venous system and whatever extremity they're located in. They break off, they go to your lung, cause something called a pulmonary embolism, which can be fatal. Okay, see it. I'm an emergency physician. I see this a lot. Unfortunately, I see a lot of PEs. I diagnose PEs probably twice a week, 3 times a week, and probably at least once a month I get a cardiac arrest from a presumed PE. I don't always know if it's a PE at the time, but a lot of times it's very suspicious for a PE. Or when we get the patient back and we do a bedside echo, we see their ballooned out right ventricle, and we presume it's a PE. But anyway, if you come in with an upper extremity clot and you don't have chest pain, you don't have shortness of breath, there's still a 40% chance that you have a pulmonary embolism. And same thing with your lower extremity. If you have a big clot in your leg, so especially if it's in the thigh, it's actually a little bit higher than that. It's above 40% chance. So you are breaking off little pieces of that clot and it's going to your lung. Okay. And that's a big problem, right? Even if you're asymptomatic from that, over time, you can develop what's called pulmonary hypertension from that, high blood pressure in the lungs. That leads to a whole bunch of other problems down the road, sometimes many years later. So yeah, I would absolutely, in my opinion, I think you should be on a blood thinner for life. I would hate to be on a blood thinner, but this is one of those situations where I would put myself on a blood pressure, excuse me, on a blood thinner after I consulted with an expert hematologist, of course. So here's the thing. This gets back to kind of what I was talking about before. First of all, you're on a terrible protocol. If you were put on a proper protocol, your hematocrit, you may not have these hematocrit issues. Okay. If you are on Xarelto, this is another question. Let's say your hematocrit does creep up. Now, and let's assume that hematocrit is actually related to thrombosis risk. Hematocrit elevations from testosterone, also dubious. But you're on Xarelto. Does that cancel out your risk? I don't know. Nobody's ever done that study. Probably does. It's just my opinion. Okay. I don't know that for a fact. I don't know of any study where they've taken men on therapeutic testosterone who had elevated hematocrits and happened to be on a blood thinner like Xarelto and then looked at thrombosis risk. I don't think that study exists. It probably never will. So the first thing I would say is get on a proper protocol and then just reevaluate things. You definitely have hypogonadism. You felt better on testosterone, which is great, but you have this background thrombophilia issue with your factor V Leiden. Yeah, that's the first step. Like, you've got to get on a proper protocol and then go from there. And then please see somebody who's knowledgeable about not just testosterone, but who understands the coagulation cascade, who understands factor V Leiden, who understands DVTs, PEs, etc. Again, probably not some cookie cutter clinic. So make sure you get somebody who knows what they're doing. But that's an interesting case. This is I've run into this actually on a number of occasions in the past. So it's not what you're going through is not that unusual. The 3 upper extremity clots is a bit unusual. I don't know anybody that's had that issue. Anyway, moving on. Next question. Here's more hematocrit stuff. Does anyone know if high hematocrit and such causes face and head redness and severe itching? Yeah, it can. Yeah, you can be symptomatic from an elevated hematocrit. Absolutely, you can. And that's one of, people think I'm like hardcore anti-donation. I'm not. If you're symptomatic from your elevated hematocrit, yeah, by all means, like, go donate some blood. Somebody else can use that blood. You might save somebody's life. But then my point is, change your protocol so you don't have to keep doing it. So yes. So the short answer to this is yes. Some people also feel very flushed. They get short of breath sometimes if their hematocrit is quite high. There are other people running around with hematocrits of 60 that are totally asymptomatic. Your guess is as good as mine why some people are symptomatic and why some aren't. Probably has to do with your underlying cardiovascular fitness and other risk factors. So, oh, this is related to elevated hematocrit and blood clotting. Would heparin help, and should I get a bottle? Yeah, so technically, yeah, if you want to put yourself on a heparin drip and run around for the rest of your life on a heparin drip, it would reduce your risk of getting a blood clot. It would also greatly increase your risk of bleeding to death. No, so you should not go get a bottle of heparin. It doesn't work that way. If it's unfractionated heparin, it needs to be on a continuous infusion. The half-life is extremely short, so it needs to be continuously dripped in. If you're talking about low molecular weight heparin, something like Lovenox, okay, that's an subcutaneous injection that's twice a day. You want to do sub-Q injections twice a day for the rest of your life, by all means. I don't know where you're going to go get a bottle of heparin or Lovenox for that matter. It's going to have to be black market because no doctor anywhere is going to prescribe that to you. Okay. I use a crap ton of heparin in my emergency medicine practice. I use it a lot. You're not going to get a prescription for heparin or a prescription for Lovenox. You're not going to get a prescription for heparin, period, as an outpatient. It's not used as an outpatient. And you're not going to get a prescription for Lovenox, which is used as an outpatient sometimes in certain conditions, unless you have a very, very compelling reason. You don't want it. Why would you want to do that, right? If you get in a car accident and you're on Lovenox or heparin and you get whacked in the head or you get blunt chest or abdominal trauma, you're in a world that you're probably going to bleed to death. All right. No, don't do that. Okay. This is back to another liver question. Doc, for those individuals who have elevated AST and ALT from weight training, is there a cause of concern if it is being chronically elevated after many years of training? The answer is no. No, there's no evidence that this actually reflects hepatocellular injury or damage to your liver. Absolutely not. Yeah, no, don't worry about it. Don't worry about it. Okay, there's another blood pressure one. I think we're getting close to the end. I've got a few more here. My blood pressure is very high for 2 to 3 hours after hard workouts, and then it goes to normal. Is this something I should be concerned about? So he didn't say how high it is. This is a little unusual. So usually in the first 1 to 2 hours after you exercise, it's actually supposed to go down. Okay, if you have high blood pressure, this is actually a great way to manage your blood pressure because a lot of times for 12 to 18 hours after a bout of intense exercise, you're going to have slightly lower blood pressures for the rest of the day, and that's really good. So if it's high when you're exercising and then it stays high for up to 3 hours after exercise, that's a little bit unusual. It makes me wonder, what's going on. Are you dehydrated? Okay. Did you take a bunch of pre-workout stimulants, etc., before your workout? If you did that, like clearly it's gonna, that natural drop in blood pressure, it's probably not going to happen if that kind of stuff is in your system. Also, NSAIDs. A lot of guys don't know this. If you take a bunch of ibuprofen or Celebrex or naproxen or whatever before your workout, or if it's in your system, that the inhibition of the prostaglandins actually can impede or impair that natural drop in blood pressure after you exercise. So ask yourself those questions. That could be what's causing this. That's the only thing that comes to mind. So lay off of that stuff. Lay off that stuff. Okay, this is related to subcutaneous injection of testosterone. Can you use sub-Q with enanthate? Yeah, absolutely. Norma test E 250 per ml with a dose of 0.5 every 5 to 7 days. Thanks for all the information. You're very welcome. Yeah, absolutely. You can dose any of the esters subcutaneously if you so choose. Totally up to you. Okay, this is a good one. High E2 linked to aggressive prostate cancer? Question. So the answer is, but as always, it's not what you think. So men with baseline elevations in estradiol do tend to have, if they get prostate cancer, first of all, they are more likely to get prostate cancer, it seems, and they're more likely to have perhaps more aggressive prostate cancer. They think that this is related to stimulation of the estrogen receptor alpha receptor as opposed to the beta receptor, at least in rats. This has not been proven in humans, but suspected to be the case. So, very interesting. So what's up with that? So is it actually the estradiol, the elevated estradiol in these men that is causing them to, first of all, develop prostate cancer, and second of all, to have more aggressive prostate cancer, right? Or is this a case of association but not causation? So the way to figure that out is you have to do a study where you give men with prostate cancer or men that are at high risk for prostate cancer. We have studies with men who have prostate cancer. You have to give them estradiol and then see what happens. Do they get a more aggressive form of prostate cancer? Or if their prostate cancer has been treated, do they get a recurrence of their prostate cancer, right? So that's how you figure it out. And the truth is, what we know so far from studies like that, which have been done, is they don't. In fact, men that are on androgen deprivation therapy, a lot of times they benefit from being given estradiol, right? It helps offset some of the bone loss and the vasomotor symptoms, it improves their quality of life. But guess what? They don't get a recurrence of their prostate cancer above baseline, right? They don't develop new prostate cancer above baseline when you give estradiol. So what's going on here? Well, I mean, think about this logically, right? So what is it about men that have high baseline estradiols? If you take two men and they have different estradiol levels but similar testosterone levels, what do you think is causing that? Well, where does it come from, right? It's visceral body fat. So visceral body fat is, there's a lot of aromatase, as you guys know, in visceral body fat, right? So they're going to have more estradiol. Well, visceral body fat doesn't just produce aromatase. It produces well over 100 different, mostly pro-inflammatory cytokines. Or they call them adipokines. Okay, all of these are related to increased risk of multiple different cancers, not just prostate cancer. And there's very good epidemiologic data showing that increased visceral adiposity is absolutely related to an increased risk of development of prostate cancer and development of more aggressive prostate cancer, right? So is it estradiol or is it visceral body fat? What do you guys think? We know that when we give the estradiol, it doesn't make things worse. In fact, a lot of times it improves things, makes quality of life better. It's the visceral body fat, guys. So this is a great example. We see this, all this is like such a basic concept that some people really have a hard time wrapping their heads around. Just because things are associated doesn't mean that they're causal, right? So, eating popsicles is strongly associated with increased risk of sunburns in children. It's true. More popsicles, more sunburns, right? Do popsicles cause sunburns? No. When do you eat popsicles? Typically when you're a kid, right? When you're running around in the summer at the beach with your shirt off, what do you want? You want a popsicle. I know I did. You're more likely to get a sunburn, right? It's not the popsicles. So this is kind of the same thing. All right. So I hope that clears this up. Association does not mean causation. Okay, final one here, guys. Do you like Vasepa for improving lipids and possibly reducing arterial plaque / calcification? Thank you, doctor. Okay, you're welcome. I don't love Vasepa. So Vasepa is EPA. Like in fish oil, there's DHA and EPA. So Big Pharma decided to turn this into a drug, highly purified, high potency EPA, and have marketed it to people with lipid disorders and coronary artery disease. It's really good at reducing triglycerides. It's very good at reducing CRP, so like addressing residual risk from that. In general, I think you should just eat oily fish. I mean, I think that's probably better for you. By all means, like if you want to take some Vasepa or supplement with fish oil, I don't have strong objections to that. What does it do? You can get triglycerides down by about 20 to 30% compared to placebo. It does drop LDL a little bit. It drops ApoB by I think it's 7%-ish, 6 or 7%. So these are modest improvements in LDL, ApoB. It can drop CRP by 17, 18%, which is pretty decent in my opinion. So you could definitely consider it for that. There's no studies out there that shows it reverses arterial calcification. So it's not going to drop your CAC scores. Not a single study that shows that. There was something called the Evaporate trial, which showed that maybe if you took this stuff, that it could slow the progression of atherosclerotic plaque, maybe reverse it in the right situations, but maybe it could slow atherosclerotic plaque a little bit. So I'm not in love with Vasepa. I think it's fine as an adjunct. If you're really close to goal, or you got a triglyceride issue that you can't seem to address with diet and lifestyle intervention, you can throw some Vasepa in there. It's like monotherapy with this. That's probably not going to get you to your goal, but talk to your doctor about it. Like your individual circumstances might be different. So, okay. Okay, cool. That was the last one. All right, guys, I hope you like this. If you have any questions, if you want me to give you some more details about any of the things I talked about, let me know. I will try to do these. I set a goal to try to do these once a month. I'm not going to promise, but I'll do the best that I can. And try to give you guys, again, you ask me very detailed questions. I want to give you detailed answers more than I can just, like I said, type on my phone at times. So I'm just going to use this as a format to do that. So hope you guys enjoyed it, and I'll catch you next time.
Land Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.